So if someone told me, I have a patient who came from Liberia, we think they have a history of cancer, and they've had nausea and vomiting for 6 weeks, I would tell you that is not Ebola. Ebola is a short-lived disease. People do not have symptoms for 6 weeks. So I think duration of symptoms should be part of the screening just as much, but currently that, again, it's the difference between how we do epidemiologic investigation versus how we do clinical care. So how do we make the diagnosis? Both in West Africa and in the US, we use a molecular test. So we use PCR, it's an RNA virus, and ultimately what we're doing is we're extracting the RNA and we multiply it over time and put primers against it to see if they signal that that RNA is there. And the PCR is quite sensitive. The dilemma is that PCR cannot be done except in very high biocontainment labs. So if you're a US hospital and you need to rule someone out, most of the laboratory response capability in the US is for diagnostics to rule someone in. So they're going to ask you to do a whole bunch of things before you rule them out. For us, the rule outs are so much more problematic because they happen so much more frequently, and also they stop your emergency department. They stop your hospital from being able to do work. So I would argue most of our laboratory capacity should be about the rule out. Because honestly, if I have someone who I'm really suspicious has Ebola, and it takes the CDC 12 hours additional for me to know about it, I have no problem with that, because we're already isolating them, we're already expecting that they have it. It's the person who I think doesn't have it that I really want to be able to get out of isolation so we can get our work done again. So the struggle we've had is really what is the throughput through the laboratory response network, as well as what's their process for determining whether or not they'll do a test. I think they're getting better at being able to do rule-out tests, but there's also another product that just recently became available. The FDA just allowed for emergency use authorization of this Ebola test, and the nice thing about this test is it does not require a high biocontainment lab to be able to do it. It can be done at an academic center or any other good clinical lab to be able, the package is done in such a way that you're never going to be exposed to a high-risk sample. So the BioFire, I think,